Every single bus stop, every single building in Chicago right now has an ad for an immunotherapy product. O'Hare Airport's littered with them. Clearly, IO has been the big thing for a lot of cancers. Where are we with this in panc? I've never even seen an MSI-High Panc. Is anybody?
Yeah.
You got some? All right. Tell us a story.
This was part of the study, but individualize it to the level of the patient. This was a patient with Lynch syndrome who had gone through colon cancer and uterine cancer and then pancreas cancer. In fact, had it resected and then came back and was treated with gemcitabine, nab-paclitaxel with no response, and then were referred to a study with pembrolizumab that we had then with MSI-High tumors. This was 4 years ago. Within a few months, the patient went into complete remission. Her CA-99 normalized completely. At 9 months, she started having some neuropathy, which was very intriguing, and it ended up being an autoimmune reaction. And we had to stop pembrolizumab at 10 months. She remained in CR, and she remains in CR now for 4 years after. I
think about immunotherapy toxicities, and I'm very glad I went to internal medicine training. I diagnosed a pan-hypopit the other day. I felt very proud of myself. How frequent is this problem, this genetic abnormality, and how important is this for pancreas cancer?
I mean, I think it's an important, but it's a rare event, and we certainly have to keep that in mind. I would say the best data we have suggests about 1 to 2%. We looked at 800 plus people. We found 7, so it's 0.8% incidence. They all had
people living in Manhattan, or is that? Yeah.
That's all of the people that we sequenced, and we're able to look for somatic or germline mutations in MMR genes, consequent of next generation sequencing. All had germline Lynch, and 4 of those individuals have benefited from immune therapy. And one lovely story, in a way, like Tony's patient, lived for 10 years plus with advanced pancreas cancer, died actually of another Lynch-related malignancy, and had tangible benefits, durably so, from immune therapy.
You know, we've been also very excited about MSI-High and the approvals really founded in some of the colorectal and other GI malignancies. But the more we've been looking at the data of it's certainly single agent and even really combination immunotherapy, even in the MSI-High patients, it's not like it's a home run. It's not like kidney and melanoma.
Well, to add to that, so this gentleman developed 2 other Lynch-related malignancy while on pembrolizumab, but yet his pancreas cancer, metastatic pancreas cancer, remained controlled. Fascinating, right? I'm trying to learn as much as we can from
different biology.
Yeah.
So I would just add that you probably need to give chemotherapy first. I had the experience of giving a checkpoint inhibitor to a patient before chemotherapy, so we gave it first line. I called Hopkins, and they gave me approval. And the patient basically had lots and lots of toxicity. So it made me very aware of, and I think some of the trials in other GI cancers were giving chemo up front, kind of culling the disease, reduce some of the inflammation, and then using some of the checkpoint inhibitors. The other thing I'd say about this MSI, there is an MSI-like. You know, the Europeans looked at that in colorectal. I think we need to explore that more. Some of this tumor mutational load work may also be important to try to broaden the number of patients that can benefit.
So to get to that molecular testing, you need a piece of tissue. And I struggle with this part, is that very often the diagnosis is made with an FNA and a few cells, and we can't do really broad testing. We talked a little bit about that earlier. Is MSI enough to take a patient with metastatic disease and biopsy of them for molecular profiling, or is it part of a larger puzzle? Would you re-biopsy somebody to do genetic testing if you didn't have adequate tissue in the bank?
It's a great question. I mean, I think that the outcomes with immunotherapy in MSI-High patients are enough to justify it, because it's another option for them. It's a potentially meaningful option, as Tony has illustrated. I mean, obviously not everyone has great outcomes on these drugs, but certainly I think that the chances of that are significant enough that I would put them.
Well, and it's not just MSI.
Right, it's tumor mutation.
BRCA,
right,
it's
BRCA.
BRAF, it's others.
Yeah.
And unfortunately, again, if circulating tumor DNA was predictable enough for us, first of all, we cannot get a tumor mutational burden yet on these liquid platforms as a surrogate of MSI-High. So we don't have that capacity yet in pancreas cancer. I think biopsy remains king or queen.
I feel strongly about getting biopsy. I think it's justified, and it's what Tony just said. It's not just MSI, it's all sorts of mutations that hopefully we can target. There's also re-biopsy clinics where after a patient progresses, you biopsy them again. We've talked about this before. I think we've struggled with the empiric approach of treating everybody to benefit the few. I think we need to be smarter and really understand what the tumor is doing, especially in pancreatic cancer when you have so many underlying mutations. So I don't have a problem with biopsy. It's the insurance that has a problem.
I run a nationwide precision medicine alliance, and so I'm theoretically supposed to know what I'm talking about, but there's so much I don't understand about, the way these tests are run, giving me a positive or negative, the variants of unknown significance. And so we're all learning on the fly here a bit. Whether it's determining BRCA or the in-track, you need the fusion, not the mutation. And I think a lot of our colleagues, I know that because if it's true for me, I'm assuming it's true for others, is that you have this report in your chart and you really don't know how to interpret it and don't know if it was done with the best quality.
I couldn't agree more, John. I think we're really in the discovery phase of this and still learning how to apply this information and trying to sift out what's important and what's not. It's one thing to have an actual finding. It's another thing to have a drug. It's another thing to combine them in pancreas cancer and say this works, right? And there's very few observations that we're there for yet we see these quotes, and I think we're all guilty of it, of saying there's 30% or 50%
Actionable
actionability,
mutations, yeah.
but we just don't know. So, but nonetheless, I think it's very important that we're doing this so that we learn.
Yeah.
And we'll be able to hopefully better apply this going forward.
And I am so, in a way, grateful for the insurance industry and the FDA to kind of look the other way. I shouldn't say that on camera, but this is really still research in many ways. There are some standard of care things that justify the test. But doing it in all patients is increasingly, and just like we get a CAT scan on every patient, I think we're moving to a world where we'll have broad molecular profiling on every one of our metastatic patients.
I agree.
All right, let me be the moderator for a second. Patient gets through all available treatments for pancreatic cancer. Are you going to give them a checkpoint inhibitor?
Not going to lob
Last-ditch
the Hail
effort?
Mary. No,
Hail Mary?
absolutely not.
No?
I think it's
Not
inappropriate.
outside of a clinical trial. I think the data, and not outside of MSI, I think the data just do not support that.
The patient, the
Patient wants
marketing,
it.
yeah.
Well, and what's interesting in a sort of crazy world that we're in, the company will send it to you without much. So it's not like they're even charging.
So
they'll say it's worth it, give it a try. But I would say that's not.
We've
So
already
it's not
coined a
placebo.
term.
It's not placebo.
It's not placebo. It has its toxicities, and it has its detriment on the patient's timelines in terms of acceptance of what's coming. And also, I think it doesn't help bring closure to the patient and to the family. And we have to think about these angles as more important than just, we're trained as physicians that we have the duty to continue treating. That's not true. We are always humbled in oncology to take a step back and think that death is part of life for a lot of these patients and their families, and it's important to make sure that transition ends up being very comfortable and very comforting to the patient and to the family. So I actually have incredible problems with the Hail Mary approach at a point where I think that the patient should proceed with what would be appropriate, would be hospice and comfort care.